So tonight, the title of my presentation is Respiratory Disease Roundup, which will be an overview of common respiratory disorders in horses, donkeys, and mules. But the general outline tonight is we're going to start with a brief review of respiratory anatomy and physiology. We're then going to have a quick look at the diagnostic approach that we might take to a respiratory problem. And then the bulk of the remainder of the talk is going to be divided into three sections. So respiratory disorders can sort of be broadly grouped into three different categories. So the first would be infectious conditions with that little symbol next to it, so you always know kind of what topic we're on. Boom, there. The next one is going to be looking at inflammatory conditions represented by, that little symbol there. And then the final section will look at a few disorders that are related to the anatomy and physiology of the respiratory system. Next slide, please. So just starting with a quick poll, by a show of hands, how many people are involved in competitive disciplines with their horses here tonight? Okay, so maybe a third to a good third of the room anyway. And how many people, regardless, would rate athletic ability and performance as being really important to them in their relationship with their horse? Yeah, definitely quite a few more. And then lastly, how many people would rank their horse's health and welfare as being a top priority? Not surprising there. So if you raised your hand to any of these, I think this talk will have something of interest for you. Next slide. So first, let's start with some fun facts. How can we measure aerobic capacity in the horse, or really any athlete for that matter? And one of the measures that we use is called Vo2 Max, which is basically a measurement that looks at the maximum amount of oxygen. Just hold off there, whoa, that's fine. The maximum amount of oxygen that an athlete can consume during maximal exercise. So the VO2 max of a horse is commonly reported to be somewhere between 160 to 180 mils per kilogram per minute. Okay, so it doesn't account for the whole horse, it's just per unit of measure. And that is for a thoroughbred racehorse. Next point. So by comparison, the VO2 max in an elite human is about 80 to 90 mils per kilogram. So again, comparing apples to apples there, okay? So, to summarize that, horses are approximately twice what we're able to produce as far as our aerobic capacity, which is pretty incredible. So this graphic is just summarizing what I just said there, but it's going through some of the highest VO2 maxes in history. So we've got a few Tour de France competitors here. I mean, there's Lance Armstrong in there, so you might take that with a bit of a grain of salt. But Miguel Indurain's about 88. Lance, with all of that enhancement, is about 85. Then we've got a cross-country skier all the way up at 95 or 96, whatever that says. And then another cyclist at about 97.5. So, that's pretty darn impressive, for sure. By comparison, my understanding is that your average human is somewhere around 50 to 60 mils per kilogram. So these guys are definitely the elite here. And then, like I had mentioned before, comparing to our animal athletes, your thoroughbred racehorse is coming in at about 180 mils per kilogram. But not to get too big-headed with that, the Siberian Husky actually comes in at about 240 mils per kilogram, which is pretty darn incredible. So some other measures of athletic capacity or aerobic capacity in the horse. So as far as increased oxygen uptake during exercise, next point. So a horse is able to increase their respiratory intake by about 40 times over what they do when they're at rest, which is, again, pretty phenomenal. Next point. The human will increase that by only about 6 to 8 times. So, pretty significant difference there. As far as increased respiratory rate, the horse will increase their breaths per minute to up around 180 breaths per minute, whereas the human athlete is about 60 to 70 breaths per minute. So again, a pretty significant difference. This little chart here just shows, again, a few fun stats. So comparison of various flow rates, and this is in liters per second. Water over Niagara Falls, about 600,000 liters per second. Airflow velocities in exercising horses, 64 to 79 liters per second. And about twice of what you're gonna, well, not quite twice of what you're gonna get out of a hairdryer. whereas an exercising human is down there at about 4 liters per second, and molasses in January is reported as too slow to measure. I'm really not trying to dog on human athletes here either. I just hope it really highlights just what amazing athletes horses are. So it's also been reported that of the total amount of energy a racehorse needs to finish a 5-furlong race, which is just over about half a mile, about 70% of that will come from aerobic metabolism, okay? The same can be said for a show jumping horse, about 70%, and that a horse completing the cross-country portion of a 3-day event is at about 90%. What do you think about that, Sandra? Does that sound about right? And even in a quarter horse race, typically a quarter mile, still about 40% of the energy that they use to run will come from aerobic metabolism. So pretty important to their ability to function. So many of us will remember that one teacher back in high school that when teaching biology would always compare your lungs to a certain number of tennis courts when you spread them out. Is that ringing a bell for anyone in particular? So for horses, we'll just bring up the next point, if all of the airways in the lung were opened out and laid flat on the ground, they would occupy a total area equivalent to, oh gosh, I was gonna have to guess. Okay.
Spoiler.
We're gonna be like a married couple by the end of today. So about 10 tennis courts. You're right, Kirby, you got that one. So next point. So don't do it yet. Human lungs, what would you say in comparison? 1. Okay, you guys paid better attention in biology than I did. But yeah, about 1 tennis court by comparison. Okay, so that's kind of the end. Oh, I just turned off my mic. Hello? There. Okay, so now we're going to start drilling down a little bit more into the respiratory anatomy and physiology of the horse. So at brief glance, as with most things in life, it's a pretty simple system. Essentially, we've got a tube that brings oxygen from the outside down into the lungs where it enters the bloodstream, and carbon dioxide from as a waste product gets expelled back out again, right? It's just a tube. Come on back, we're not quite done there yet, thanks. And like most things in life, it's very, very simple, but it's also very, very complex. So this figure on the right is a close-up of essentially this area of the horse's head. So kind of the back of the nasal cavity here into their back of their throat, and then the beginning of the trachea there, okay? So I include this here because this is a common trouble spot in a lot of horses, and it's important to kind of have a bit of an understanding of what this anatomy is. So just to orient you a little bit further, this is the horse's mouth right there, obviously closed and nothing in it. And this is the nasal cavity. And they're separated by a hard palate, which is right there, and a soft palate, which is here, okay? And that soft palate will extend down to the larynx, which is this opening there, and the epiglottis will protrude out of that and sit flush with the top of that soft palate. Everybody with me so far? And that is important because that forms a nice tight seal in the back of the horse's mouth, enabling minimal sort of resistance as the horse is breathing back and forth, okay? So essentially, again, just one straight tube, but a lot of points, or a lot of parts that are connected to that. And what you might also realize from this, as many of us already know, is that horses are what we call obligate nasal breathers. In other words, they can only breathe through their nose, they don't breathe through their mouth. The other thing I'll just briefly point out here as well is this structure. So it's not quite accurate here, but that would represent approximately where the guttural pouch would exist in the horse's head, okay? And that's a pretty important anatomic area that is the source of some problems that we will see. So just in short, we're going to revisit this again later, but there's essentially 2 guttural pouches at the back of the horse's throat, one on either side. And I've got some other pictures to show you that in future, but just to point that out at this point. Next slide. So again, the respiratory system is essentially a glorified tube, starting with the nostrils, moving on into the nasal cavity, the pharynx, which is that space right at the back of the throat, and then the larynx, which is sort of the area that we use to divide the upper respiratory system from the lower respiratory system. We then follow the trachea down into the lungs, which include the bronchi and bronchioles, and eventually the alveoli, which are the little air sacs right in the terminal branches of the lungs, and then eventually into the bloodstream. So it's important to note that trouble can brew anywhere along this tube. Next slide, please. So a little bit about the physiology of how horses breathe. So a horse at rest or while walking or trotting will breathe just like we do by expanding and contracting their chest. In other words, it's not paired with their stride. When a horse starts to canter or gallop, however, breathing becomes perfectly timed with the stride. So that means that there's one respiratory cycle, or one inhalation and one exhalation per stride. And the amount of air, logically then, that is moved will increase as the horse runs faster. Next slide. So this graphic will give you a bit of an idea of that. So, these images kind of in the center of the screen when the horse is at maximal extension in their stride, obviously you've got that nice long underline that's causing maximum expansion of the chest cavity and to act like a bellows and really forcefully draw air down into the lungs. And by comparison, when the horse is gathered up under them, under this phase of the stride, that chest is compressed and air can be forcefully expelled from the lungs. Okay? So this makes a lot of sense when a horse is running at speed to pair those two things together. Next slide, please. So I come from a bit of a standardbred background as well. At one point I wanted to be a driver trainer, and I've always thought, well, what about this guy, who's also exercising at maximal capacity, but he's obviously using a very different kind of a gait. And in this case, the horse is able to decouple the stride from the breathing and essentially have the breathing match their level of exertion. So I just think that's kind of an interesting point. Does anyone know who this horse is by? Just for fun? Not a lot of standardbred people here? Okay, he's some beach somewhere. He's a Canadian horse, and he was one of the best in the world, actually, at his time. Next slide. So just because I'm a bit of a standardbred fan. Standardbreds, because who wants to canter anyway? Is Kathy here? Gosh, she'd kill me if I said that. So why do we care about this? Well, respiratory system dysfunction has been reported as the second leading cause of exercise intolerance and poor performance in the athletic horse, following musculoskeletal disorders, so typically lameness, and structural, functional, and infectious conditions can occur at any point. Next slide, please. So a lot of these conditions aren't going to mean a lot to you right now. Some of you may have heard of a few of them before. But just to give you a bit of an idea of some of the prevalence of some of these disorders, we've got dorsal displacement of the soft palate, which occurs in about 10 to 20% of athletic horses. Laryngeal hemiplegia, which we will commonly call roaring, will occur in about 5 to 8% of racing thoroughbreds. Epiglottic entrapment, we don't worry about that one so much. Exercise-induced pulmonary hemorrhage can occur in as many as 87% of racing standardbreds and 95% of racing thoroughbreds. So very, very prevalent. And inflammatory airway disease in as many as 50% of racing thoroughbreds and standardbreds as well. Next slide. So what does that look like when a problem exists with the respiratory system? So we might see things like a snotty nose, a cough, noisy or abnormal breathing, obviously exercise intolerance, abnormal eating, swallowing, acting dull or depressed, having swollen lymph nodes in the head or in the throat, or a fever as well. So as a veterinarian, we use a number of different sort of algorithms or kind of thought processes to try to drill down and try to determine where does the problem exist and what is the nature of that problem. Is it something that's infectious? Is it inflammatory? Or is it something more that's anatomic or physiologic? So this is just kind of an example of an algorithm that we might run through. I would like to point out, and I think probably most people know this, but it's worth mentioning that there's a difference between things that are infectious and things that are contagious. And we're going to be talking about both of these things as well. So things that are infectious are not always contagious, okay? But everything that is contagious is also infectious, if that makes sense. Next slide. So here's just kind of a brief list of our arsenal as far as diagnostic tests go. And all of these tests can essentially be summarized as things that help us to examine, to sample, and to image to try to get an answer when there's something going on with the respiratory system. So as far as examining goes, we can take a good history and figure out kind of what's been going on with that horse, do a good thorough physical examination, perhaps a rebreathing exam to get a better listen to the lungs. We can run blood work, obviously. And then we get into taking samples such as, sorry, that's supposed to say nasal or pharyngeal swabs, or sampling different parts of the lungs to look for signs of infection or inflammatory cells. The other thing we can do is endoscopy, or basically sticking a camera up the horse's nose. And when we do that, we can look at either the upper or lower respiratory system, and we can do this as either a dynamic or a static scope. So some people, I'm sure people have seen seen pictures of static scope before, and basically that just means that the horse is standing there in the stocks, in many cases, or in some cases sedated, with the camera going up their nose so that we can have a look at something in the nasal cavities, the back of their throat, or even the first part of their trachea, okay? The problem with that is that a lot of conditions aren't going to be apparent when a horse is resting. In other words, they're only going to be obvious when the horse is exercising, right? So how would we diagnose those? Well, we now have the ability to use what's called a dynamic scope. So this horse here, I don't know if you can quite see that, but it's basically got an endoscope attached to a special bridle that's in its nose while it's exercising. And that camera will transmit to a backpack that can then wirelessly transmit that image to a monitor somewhere. So what that enables us to do is actually have a look at the airways while the horse is exercising, which is a pretty significant advancement in our ability to be able to diagnose some of these conditions as well. Sorry, my slides got a little messed up there, but last things we can do as far as imaging goes is take chest ultrasound or x-rays, or do a blood gas analysis. Next slide. Okay, so we're entering sort of the first major category of respiratory disease here, and this is the outline. We're going to talk about viral conditions, and obviously this is not an exhaustive list, but I'm going to focus on two of sort of the most important viral infections of the horse's respiratory tract, those being equine herpes virus and equine influenza virus. We're also going to talk about bacterial infection of the respiratory tract, so including strangles, pneumonia or pleural pneumonia, and a brief look at another one called Rhonococcus Equi. So we can also divide these conditions by their location in the respiratory tract. So we have conditions that affect the upper respiratory tract, such as herpes virus, flu, and strangles, or things that can primarily affect the lower respiratory tract, which in this case could be a bacterial pneumonia. So starting with equine herpes virus, this is a very common virus worldwide, and it's considered to be endemic in virtually all horse populations. There are different strains of this virus, and as far as respiratory disease goes, we're mostly concerned with equine herpes virus 1 and 4, and more recently a little more concerned about equine herpes virus 5, and we'll explain that as we go forward here. It's important to note that this is all the same virus, equine herpes virus, but it can cause different manifestations of disease, okay? So again, tonight we're mostly focusing on respiratory disease, so this virus can cause that, but it's important to note that it can also cause abortion and neurologic disease. A lot of horsemen will know this disease more commonly as rhino, and that is because the clinical condition it causes is rhinopneumonitis in the horse. So what do we need to know about herpes virus? It's important to realize that many or even most horses will contract this virus as foals. They then carry it for life as a latent infection, okay? So a more common clinical presentation is to actually see signs of infection in foals and yearlings, and usually around the fall or the winter, okay? However, our older horses that have been infected in the past and maybe got over that infection a long time ago can still potentially transmit that virus without showing symptoms, okay? And mules and donkeys can also be silent shedders. So as far as clinical signs go, this one can be a hard one to catch sometimes. So typically you get a fever that will come in 2 waves. So a horse might have a fever at day 1 or 2 after they're first infected, and then again at day 6 and 7. And sometimes that's the only clinical sign that they will have. So it's very easy to miss that, and in fact, probably most of the time we do miss that. In other cases, clinical signs can range from basically none to quite severe. And they can include, typical things that we would see with a respiratory infection: fever, coughing, a snotty nose, swollen lymph nodes, and weepy or inflamed eyes. Transmission is primarily through the respiratory route, although it can be through other routes as well. We typically will diagnose that based on a nasal swab, and we may submit blood as well. Treatment for viral infections are quite similar to most of the viral infections that we will have, and that is, essentially there's not really a lot of great drugs, or particularly drugs that are affordable against viruses. So typically we treat these infections through isolation and supportive care, and we let the horse's immune system kind of take care of it. So the key point here, though, is that horses that recover from this infection can still carry the virus, and it can reactivate in times of stress to infect other horses. So just a quick human example for those of us that have had cold sores before. Often when we're kind of stressed out, that is also a reactivation of a herpes virus in our own system as well. So as far as vaccination goes, vaccination can reduce shedding of virus as well as the viral load in the blood. It helps to prevent respiratory disease and abortion, but it is not proven to prevent the neurologic form of the disease. However, repeated vaccination will reduce the frequency and severity of disease, and it can also help limit abortion storms. So current recommendations for vaccination for pregnant mares, obviously this is more for abortion, but we recommend vaccination at 5, 7, and 9 months of gestation. For foals, first vaccine at about 4 to 6 months of age, booster that in about 4 to 6 weeks' time, and then one final at 10 to 12 months of age. Okay. Adults that have been previously unvaccinated should ideally get a 3-dose series at a 4 to 6 week interval, and then again at 1 year from the first vaccine, and then a 1-year booster thereafter. The exception to that would be horses under the age of 5, those that are exposed to brood mares, or those that are at high exposure risk, so ones that are going to competitions, that are exposed to a lot of other outside horses and traffic as well. The recommendation there would be to revaccinate them every 6 months. So this is just one little aside, but I thought it was worth mentioning that equine herpes virus 5 hasn't always been thought as being that damaging to the equine respiratory system, but it is, essentially ubiquitous. It's pretty much everywhere, and many normal horses will have this virus. More recently, chronic infection with this particular strain has been linked to the development of a disease called equine multinodular pulmonary fibrosis. So what that is basically areas of the lung that are, or multiple areas of the lung that start to become firm and hardened, and they're not able to expand and contract as usual. So as you might imagine, that makes it very hard for the horse to be able to breathe, appropriately. The horse will have signs of respiratory dysfunction, and they may have a fever, but this can often look like other conditions. So it can often be misdiagnosed as a pneumonia or a Hepes as well. As the disease progresses, it can become quite severe, and it is a very serious disease. And we have seen one example of that in our area over the last few years, one that I'm aware of. Equine Influenza. So again, this is a flu virus, and for those that like the nitty-gritty, it is an H3N8 orthomyxovirus. There will be a test at the end of this. Not really important for you guys to know, but there are multiple strains, and typically those are divided into American and European strains. And of the American strains, these are the ones that cause the most disease in our area, and those are further divided down. The flu virus is endemic in pretty much every population in the world except for Australia, New Zealand, and Iceland. Go figure. I thought that was kind of interesting. I wonder if they could do that for the human flu virus. That would be nice, eh? So what do you need to know? So this is a pretty contagious infection, obviously respiratory route of infection, so through coughing and other respiratory secretions. Unlike herpes virus, it does not produce latent infections, so that's on the plus side. So for a horse to get the flu, it has to come from another infected animal. So that does mean that we're more able to prevent the spread of this disease through isolation, vaccination, and quarantine protocols as well. So the severity of clinical signs will depend a lot on the degree of immunity, and it is possible to have partial immunity to this disease, okay? So a partly immune horse can become infected and it can shed the virus, but it's also less likely to be as sick as an unimmunized horse would be. Again, typical signs of respiratory disease: fever, lethargy, nasal discharge, and a cough. As far as vaccination goes, if a horse just gets the flu virus without being vaccinated, that in itself can make them immune for up to about a year. All current flu vaccines are licensed to protect against infection and transmission for about 6 months. And current vaccines will typically have a lot of those multiple strains that I was identifying earlier on. So it is important, though, just like the human vaccine will be updated every year. I don't think we're not updating our horse vaccines or our horse flu vaccines every year, but they are getting updated every couple of years. There is also a modified live version of this vaccine that uses the intranasal route, so the same way that we give Strangles. This has been proven to provide pretty excellent or pretty good immunity with a single dose and with boosters every 6 months. So that might be one to consider, particularly if your horse is prone to reactions to an injected vaccine as well. So further vaccine recommendations for foals, this is pretty similar. Vaccinate at 4 to 6 months of age, booster that in about 4 to 6 weeks time, and then again at about a year of age. For adult horses that are unvaccinated, we again recommend a 3-dose series with the second dose at 3 to 4 weeks after the first, and then the third dose at 3 to 6 months, although often that will happen at about a year post. Adult horses that are at low risk may receive an annual booster, or in some cases, if they have 0 exposure, then that may be omitted. Adult horses that are high risk should get it about every 6 months as well, every 6 months. Pregnant, vaccinated mares should be vaccinated about 4 to 6 weeks before foaling. That's just to make sure that their colostrum is going to have some immunity or a good amount of immunity to pass on to their foals. And pregnant, unvaccinated mares should receive the same 3-dose series there. Okay, so everyone's favorite, Strangles. Strangles is we're moving away from the virus and now into the bacterial infections. Strangles is a bacterial infection of the upper respiratory tract that's caused by this organism here, Streptococcus equi, subspecies equi. It's a highly contagious infection, especially among young horses, but it is important to note that horses of any age are susceptible to infection. So similar to herpes virus, even though this is a bacteria, once a horse has been infected, it is possible for them to have a latent infection going forward. And the way that works is the bacteria gets into those guttural pouches that I was describing to you earlier, and essentially it can live there without any signs of disease. So a horse that has Strangles is able to carry that infection in that guttural pouch and won't always be shedding it, but occasionally that bacteria can be reactivated and shed into the environment. So how does your horse get it? Basically, they get it from another infected horse or from the environment, and the I guess caveat to that is that it has to be in the environment that's been recently infected. Strangles is not an organism that lives for years or even months in the soil, like I've heard before. The more recent data on that is that Strangles typically lives for maybe a couple weeks, and in standing water it can live for about 6 weeks. So that's kind of the most critical control point there. Clinical signs, well, not a pretty picture. You see fever, a horse that's having a difficulty or an inability to eat, swollen lymph nodes that can turn into abscesses, and copious thick nasal discharge. As far as vaccination goes, there is a killed vaccine that's injectable, but it doesn't really prevent disease. It may only just make it a little less bad. So we typically will use the modified live vaccine, which is given through the intranasal route, which is how as a veterinarian you find yourself doing this quite a bit, and questioning your life decisions. So it does generate a very strong immune response at the site of transmission. So that is the tonsils, and for it to be effective, it actually has to reach the tonsils. So that is the reason why we have that little tiny tickly straw that we have to get as far up your horse's nose as possible and then blast them with that vaccine. And they have absolutely no idea why we would do such a thing. So recommendations for strangles. For foals, we recommend a 3-dose series beginning at 6 to 9 months of age. And then we boost that at 1 month after the initial, and then again at 1 year. So similar to those other vaccines. For adult horses that are unvaccinated, they should receive a 2-dose series at about a 3-week interval, and then again boost at 1 year. And for adult horses that have been vaccinated, an annual booster is usually sufficient. Moving on to pneumonia and pleural pneumonia. So we're now moving from contagious infections to an infection that is not contagious, okay? So basically when we're saying pneumonia, we mean an infection of the lungs. We can have bacterial, viral, fungal, or parasitic infection of the lungs, but in most cases, what we're talking about, or the most clinically significant, are bacterial infections of the lungs. Pleural pneumonia is a variation on pneumonia, where basically the infection extends from the lungs themselves into this area that's called the pleural space. So basically the lungs sit inside the chest, inside basically a 2-layered bag. And for the lungs to expand and contract, those layers of that bag need to be able to glide back and forth really easily. So usually in a normal horse, there's just a very thin layer of fluid between those two surfaces. When an infection extends from the lungs into that area, then that fluid becomes thicker and thicker and thicker, and it can actually compress the lungs and cause pretty significant disease. So how does pneumonia develop? In almost every case, it will develop secondarily from another primary illness or a risk factor. So basically something happens that depresses the horse's immune system and their natural senses become overwhelmed, and that results in bacterial colonization of the lungs. So basically a normal healthy horse, their lungs should be essentially sterile. There shouldn't be any bacteria there, and they have a number of different defense mechanisms to keep bacteria from getting down there, okay? So things that can actually interfere with the immune system and cause an infection to develop are recent long-distance transportation, particularly if the horse was confined with their head elevated. Exposure to other horses while under stress, going through anesthesia, having an increased level of training, especially entering into high-intensity training, continuing through training in the presence of a respiratory infection, having a viral infection of the upper respiratory tract, such as getting over a flu or a bout of herpes virus as well, recovering from a recent episode of choke, exercise-induced pulmonary hemorrhage, and old age. So risk factors are essentially the key to the development of this disease. The bacterial pathogens themselves are typically not really able to set up an infection unless something has opened the door for them, and they're unable to cause an infection on their own. So what does this look like? So in mild cases, you may actually not have many signs at rest, or the more common sign would be a fever and the horse just feeling pretty crummy and acting pretty lethargic. Other things you might see are reduced appetite or going off their feed, any signs of chest pain, an increased breathing rate or effort, a snotty nose, a cough, or weight loss. As far as treatment goes, so pneumonia and pleural pneumonia are definitely life-threatening conditions that are very serious. So to treat these conditions, we typically have to hit them pretty hard. So, the typical course of treatment might involve multiple repeats of blood work, multiple ultrasounds, potentially some x-rays, and aggressive long-term antibiotic treatment that can last as long as 3 to 6 months may be necessary in some cases. In the case of pleural pneumonia, we sometimes have to drain the fluid from the chest. We have to provide anti-inflammatories, and laminitis can be another disease that comes along as a result of the pneumonia, so you may be stuck treating that as well. The horse may need to be on IV fluids, and in some extreme cases, they may also need to go through surgery. So as far as recovery goes, rest in the early stages is absolutely critical to prevent a more advanced disease. So a horse that's recovering from a viral infection, the recommendation there is about 3 to 4 weeks of rest as well. For a horse that's recovering from advanced disease, we're looking at about 3 to 6 months of convalescence. And unfortunately, it can still be fatal even in the face of very aggressive treatment. So as far as prognosis goes, minor or early cases may resolve just with a course of antibiotics and some supportive care. Once we get into severe or chronic infection, that's when we're talking much more aggressive treatment and a more guarded prognosis as well. So some studies have reported that, for horses that are treated for pneumonia, a survival rate of anywhere from about 68 to 75%, which seems not too terrible. But if there is an anaerobic infection that gets in there, or a particular type of bacteria, that survival rate will drop to about 35 to 38%, so not a very rosy picture. As far as finances go, they're pretty significant because of so many complicating factors. And in many cases, money may be the limiting factor as far as how far we can go to treat these cases. Okay, I should mention that hopefully there'll be time for questions at the end of this, but just to get through everything, I'm just going to burn through now, so save your questions for later. So I just wanted to talk very briefly about Rhonococcus Equi. I'm curious how many people have heard of that. Okay, not very many. So Rhonococcus Equi is a bacterial infection that causes pneumonia, more specifically in foals. So typically foals about 3 weeks to 5 months are most at risk. The organism that causes this is found in soil pretty much everywhere, but the reason why we don't always see this disease is that the strains really vary between being very virulent to sort of virulent to not really virulent at all as well. So virulent meaning the ability to cause disease. So how do they get it? Usually through inhalation and usually from the environment. It's interesting to note that this is not considered a contagious disease before animals, or between animals. So same thing as any pneumonia. It's not passed from one animal to another directly. So what does that look like? So it can have some pretty subtle signs sometimes. So anything from decreased appetite, acting lethargic, feeling kind of crummy, having a fever, to the signs you would more likely expect, such as an increase in breathing rate or effort. And non-respiratory signs are also common. So you can have abdominal disease with this infection, including fever, diarrhea, weight loss, and colic. You can also have infections of the joints, the bones, and the eyes. So unfortunately, there is no effective vaccine, so prevention really relies on the passing of passive immunity and screening. In high-risk foals and in high-risk farms, there is the possibility of using what's called hyperimmune plasma to treat foals proactively and to kind of boost their immune system as a guard against this infection. But essentially, we really rely on screening for this disease, so chest ultrasound is the most appropriate. Okay, so that's the end of our infectious roundup, and we're now moving on to our inflammatory conditions. So this section is really only focused on one thing, and that is equine asthma syndrome. So as Kirby was mentioning earlier, I went through vet school not that long ago, and when I was in vet school, we didn't talk about equine asthma syndrome. We talked about inflammatory airway disease and recurrent airway obstruction. So this equine asthma syndrome is a fairly a recent term that we've applied to it, and more commonly we call this HEAVS. So like I just mentioned, equine asthma syndrome is kind of an umbrella term that's used to link inflammatory airway disease and recurrent airway obstruction. So basically the real brainiacs in the veterinary world got together and they looked at these two conditions and they decided that there was enough similarity between them and between that and the human condition of asthma to basically call it that. Like, let's just call it what it is equine asthma. So just very briefly, the difference between inflammatory airway disease and recurrent airway obstruction, So in the first one, this typically affects horses that are under about 7 years of age. And the signs that we see there, the real classic signs, are having exercise intolerance with a cough. Although clearly that's not the only thing that can cause exercise intolerance with a cough. These horses won't have any signs at rest, so they'll be totally normal at rest. And often this condition will just resolve on its own. Recurrent airway obstruction, on the other hand, typically affects horses that are over 7 years of age. It will have multiple signs, and you will see signs at rest. It is a chronic and lifelong condition. So like I mentioned, they're both under the umbrella of equine asthma syndrome, but this reflects a difference in disease severity. And it's important to realize that this isn't a continuum. So in other words, horses that have inflammatory airway disease do not often progress to then develop recurrent airway obstruction. So equine asthma, I think most of us are fairly familiar with what asthma is as far as people go, but essentially it's a hyperreactivity and inflammation of the lower airways in response to environmental triggers, so usually dust, pollen, spores, and things like that. So there are both allergic and inflammatory components to this disease, but the most common triggers are things like mold, dust, and endotoxin, which is a component of bacterial cells that is found in hay and straw. So what does it look like? Like I mentioned before, for a horse with inflammatory airway disease, typically they're normal at rest, but they will have exercise intolerance with a cough. So for a recurrent airway obstruction, often they'll have a chronic cough, they'll have an increased respiratory rate and effort, and they may have nasal discharge from the accumulation of mucus or gunk in their airways. They can also develop a heave line and also develop weight loss or anorexia. So the primary scenarios where these conditions develop have been linked to stalled horses that are fed hay, and I would add to that in our area, also horses that are turned out on round bales seem to be very, very prone to this condition. There's also another manifestation of the disease or another scenario which is summer pasture associated, and those horses are horses that are really reacting to pollens and dusts and other things that are out there when they're turned out on pasture. So as far as diagnosis goes, in advanced cases, we can pretty much make the diagnosis based on the clinical signs and the history that we're seeing, okay? In more mild cases, we do have to do a little bit more digging to find a definitive diagnosis. So that can include scoping the airways, so actually looking in there with that camera, that endoscope, to look for mucus or signs of inflammation. The other thing we can do is sample the lungs with some fluid. This is called a bronchoalveolar lavage, and then look for evidence of inflammatory cells as well. So by doing this, we can both identify and characterize the inflammation. So in other words, does the horse have signs of inflammation in the lungs, and if so, how bad is it? As far as treatment goes, the most important treatment of all is to prevent and reduce exposure. Okay, so this can include managing the diet and the environment to reduce exposure to those triggers that I was mentioning. Mild and moderate cases can be successfully managed just by doing this. And it should also be noted that round bale hay is high in both dust and endotoxin as well as mold. I used to joke that I have heaves. I have human asthma, obviously. And when I'm around round bales, I get heavy. I actually get worse. And I don't know if anybody else has that experience here as well, but I definitely notice a difference. So like I mentioned before, horses that are stalled, the recommendation there is to turn them out, but obviously don't turn them out on a round bale. For horses that have the pasture form of the disease, the recommendation is to take them off the pasture. And in winter, they should be okay to go back out there. Mild cases, you might get by just by soaking the hay to try to reduce some of the dust and the pollen and the triggers that are in there. But in more moderate or severe cases, you may actually have to consider switching your horse to pellets or cubes. So just a few examples here as well. I'm sure we've all seen this, but and I totally understand that round bales are just the most economical way to feed horses, especially when you have a pile of them out there. But this is the condition we really want to avoid, where horses are really kind of able to dig in there and bury their noses into the hay. because obviously, while they're eating, they're also inhaling a whole lot of allergens, a whole lot of triggers for the disease. So, if you need to feed a round bale, as many people do, there are other ways you can consider doing that, such as using a netted round bale to at least prevent that burrowing, although I have used these in the past where the horses just ripped a nice hole and then burrowed their noses right into that hole. So that kind of defeats that purpose. So, hopefully get a good one that doesn't do that. Other things that you can try are actually, if you park the round bale obviously on the outside of your pen and you just fork it across, obviously you're going to prevent that burrowing behavior as well. And then if you have the equipment and if you're feeding a bunch of horses, the other thing you consider is just rolling that bale out. If you got some nice dry ground to roll it out on, I like to think anyway that it's knocking a lot of that dust and mold out of there, and it's also having the horse breathe with their nose not buried in the hay. So sometimes we need to go a little bit further than just environmental management and actually provide some drugs to treat the inflammation. So these are essentially corticosteroids and inhaled bronchodilators. So one of the more common steroids that we use is dexamethasone, and we might start your horse on a course of dexamethasone at a tapering dose over a number of weeks. We can also use prednisolone, but that typically isn't quite as potent as the dexamethasone. Other things we can use are inhaled albuterol, which is a short-acting bronchodilator. The kicker there is that you obviously have to provide your horse with a mask for them to actually breathe it, and then use a mask to inhale that medication, so not everybody has access to that. Oral clenbuterol, which is ventipulmin, we've used a lot of that in the past. It's longer acting, but it tends to lose its effectiveness when it's given repeatedly. And it's also really important to note that a bronchodilator is not an anti-inflammatory, so it's really only managing the symptoms of the disease, okay? And also in extreme cases, we can use aerosolized corticosteroids, also given through a mask as well. So that's it for inflammatory, and we're going to finish this talk on anatomic and physiologic conditions. Okay, so I've broadly divided this section into disorders that affect the throat and physiologic disorders. Again, this is not anywhere near a complete list of disorders, but it is definitely a sampling of sort of the more common conditions that we see. So we're going to talk about laryngeal hemiplegia, which is also known as roaring. We're going to talk about dorsal displacement of the soft palate and guttural pouch mycosis. Those are disorders of the throat. And then we're going to talk about physiologic disorders, and namely exercise-induced pulmonary hemorrhage. So just to go back to those first slides that we looked at to remind you of some of this anatomy here. So again, we have the nasal cavity here. We've got the pharynx, or sort of the back of the throat right there, which is sitting right above that soft palate. Here again is the larynx, and this little red item is the epiglottis sticking out of there, okay? And this area here represents about where the guttural pouch would sit. What that actually looks like on an endoscope, so if our scope was approximately kind of here, looking this way, this is what you would see. So this is the opening to the trachea right here, or the lower respiratory system, and this funky looking triangular thing is actually the horse's epiglottis. So underneath that would be the soft palate, okay? When a horse is swallowing, the food is going to be moving through the mouth here, and then as it goes to swallow, it's going to kick that epiglottis back to cover the airway and go into the esophagus right up there. So you can't actually see that here, but the opening to the esophagus sits right about there, okay? The other thing, you can't actually see it on this picture, but the opening to the guttural pouches, and there's one on either side, like I was saying before, so they would sit approximately there and there on either side of that pharynx as well.
Is that a healthy specimen?
This is a normal larynx, yes. So, recurrent laryngeal neuropathy, or hemiplegia, also known as roaring. So this has been noted as the most common upper airway obstruction in the horse. It causes abnormal, loud breathing, and exercise intolerance as well. Interestingly, it is more common in horses that are over about 15 hands high, and we typically will break it into multiple grades, so obviously mild, moderate to fairly severe as well. And so this is an abnormal larynx, and you can see it's abnormal on one side, okay? So this side here, which would be the horse's right, our left, is basically a normal larynx that is abducted or opened up. But when they have paralysis, so hemiplegia or neuropathy means that they've basically got paralysis or some degree of paralysis on one side of their larynx, okay? So the result of that is instead of being nicely opened on both sides, we've got one half of the larynx that's essentially collapsing into that trachea. So as you can imagine, horses are not really able to breathe that well. So the treatment for that is essentially to do what's called a tie-back surgery, which Dr. Lee has done at our clinic as well. Sorry, this is kind of a quick run through, but the next disorder we're going to talk about is dorsal displacement of the soft palate. So this is typically an intermittent condition in some horses that occurs during intense exercise. It results in poor performance as well as respiratory noise. So you can start to see there's a lot of commonalities between these different conditions. So treatment, there's some suggestions out there that you could treat this with special nose bands and that bits may help to prevent that. But there is yet another surgical correction, which is called a tie forward, that is used to correct that. So again, the diagnosis for this often needs to happen with a dynamic scope because it won't be present when the horse is resting. Next slide. So what does that look like? So again, we go back to our normal larynx here, and we have our epiglottis, again, sitting on top of our soft palate. When a horse is dorsally displaced, so dorsal means up, so the soft palate has been displaced up. The soft palate is now above the epiglottis. So here we see soft palate, and the epiglottis is now sitting below that. So that is actually shown in this image here. So again, showing where the camera would be, looking at that, and now we can see our epiglottis. Instead of being through that hole and sitting on top of the soft palate, it's now below that. And that results in, particularly when the horse goes to breathe out, that air, instead of having a straight shot out of the respiratory tract, is now getting caught up, at least to some degree, with greater turbulence in the back of the throat. Okay? So it's harder for them to force that air out. And now moving on to guttural pouch mycosis. So this is one of those diseases where it's kind of like truth is a little stranger than fiction. So guttural pouch mycosis is one of these things that, at least I find it really a kind of a bizarre disease when you think about it. So it occurs in the guttural pouch, which is a unique structure that's found in horses and very few other species. The guttural pouch is basically an extension of the eustachian tubes, okay? So that's the tube that connects the throat with the middle ear, and that's the source of all our problems when we're on airplanes and our ears don't want to equalize properly. That's the tube that needs to have some pressure move through it. So in the horse, that tube is basically an enlargement as well. So you get basically two air-filled pouches that sit roughly below the ears and just behind the throat, and there's one on either side. And why those pouches are so important is that they have a number of pretty darn important structures that run through that, including the internal and external carotid arteries, as well as the maxillary artery, and multiple cranial nerves. So these are nerves that are responsible for the functions of swallowing, upper airway function, as well as for some of the facial muscles, the proper operation of those as well. So here's a few photos of that. So if you were to imagine that this is sort of the back of the horse's throat, here's that tube that's starting in the pharynx and extending to the middle ear there, and this is sort of the enlargement or the outpouching of the guttural pouch. On an X-ray, this is kind of what we're looking at right here. Horses are kind of airheads, in case you didn't know that. So on a scope, this is what the inside of a guttural pouch looks like. Okay, so we've gone through the horse's nose to the back of their throat, we've gone through that little slit-like opening, and now we're looking at one of their guttural pouches. This structure right in the middle is something called the stylohyoid bone, which is partially responsible for suspending the larynx. But it basically divides the guttural pouch into two different compartments. We have a lateral compartment, which contains this, which is the external carotid artery right there. And it's pretty darn cool when you do actually scope a horse, because you'll actually see this pulsing while you're in there. And so it's a pretty massive artery there. And here, I'm not sure if you can quite see, but you have the internal carotid artery and a few of those cranial nerves coming down there as well. So what guttural pouch mycosis is basically a fungal infection of that guttural pouch. So a fungus grows on and eventually erodes through the wall of one of those major arteries. So we don't really know how that fungus gets in there, but somehow it does, and it likes it. It likes it in there, and it starts to feed on the horse's own blood supply. Okay, and so over time, that fungus is slowly eating away at the wall of those arteries. So if left untreated, a fatal bleed becomes actually quite likely. So this is when a nosebleed may not be just a nosebleed. Okay, so this is another picture of the guttural pouch that is infected with guttural pouch mycosis. So again, here's our external carotid artery, stylohyoid bone, and then you've got this black to green to tan kind of plaque growing in there, and that is what that fungus actually looks like. It's pretty nasty. So again, signs can include a nosebleed, but not always. It can also include signs such as abnormal eating and head carriage. The treatment for this, so you can use antifungals, but typically the antifungals don't work that fast, and in the meantime, that fungus is still eating away at all of those really important vessels, and so you risk, there's a high risk that at some point those arteries are going to rupture and the horse is going to bleed out. So we typically recommend a surgical treatment to go in there and actually obstruct the blood supply, and then after that surgery is done, then we may go ahead and start treating with some antifungals, okay? And just out of interest's sake, we've actually seen 2 of these cases in the last year at our clinic and have done one of these surgeries at our clinic as well. Sorry, just go back for 1 second. So typically there is a relatively good prognosis if you can recognize this early and if there's minimal or no nerve damage. In some cases, the nerve damage is pretty extensive, and even after surgery, the horse may not recover. So finally, we're at the end here. Exercise-induced pulmonary hemorrhage. So this is what I get when I play hockey, actually. And what it is basically bleeding from the lungs in response to intense exercise. And this can be diagnosed or defined as the presence of blood on an endoscopic exam and or within fluid that's taken from the lungs. So as far as prevalence goes, there was a study done in barrel racing horses in Alberta just a couple years ago, and it looked at about 170 horses that were scoped right after they run. And out of that population, 45% had evidence of bleeding. And in almost every case, or the majority of riders, were not aware that their horses had this condition. And the thought about that is that, the barrel race is, just 20-ish seconds. Oh, Screw says way less than that. For your average barrel racer, 20 seconds or so, whereas obviously a flat race is going to be, several minutes or a couple minutes in length as well. Okay, so bleeding might be visible at the nostrils in extreme cases, but that's not really the norm. Usually you don't see any signs of that. One of the only signs you might see is a cough as the horse is recovering. So again, those internal med brainiacs got together and did a consensus statement, and they reported that this condition occurs in the majority of standardbred and thoroughbred racehorses, as well as any other horse subjected to strenuous exercise. So the question there is, if it happens in that many horses, should we just call it normal? And so again, these people got together and they looked at all of the research that was out there, and they found that there was really a lot of research without a lot of really strong conclusions. But they looked at the whole kind of breadth of information that was there, and they were able to draw a few conclusions. So basically in 2015, they concluded that in all of that information, there was some evidence that that horses with severe cases may have a shorter racing career. There was also some evidence that the condition can be performance limiting. There was good evidence that the condition causes changes in the lungs, and there was also some evidence that it is a progressive disease. There was also good evidence that the drug that we typically use to treat the condition, called furosemide or Lasix, will reduce the severity of the IPH events. And furthermore, there was also strong evidence that that drug, Lasix, will improve performance as well. So based on all of that, they did recommend that EIPH be considered a disease. But I suppose the good news there is that it does seem to respond well to that drug when it's legal to use it. And my understanding is that not every jurisdiction out there will allow the use of that drug. Okay, so by way of summary here, I think just going back to the beginning of our talk, horses are extremely well adapted to maximize the use of their respiratory anatomy and physiology. That said, problems can arise at any point and can have significant impacts not only on performance but also on their health and welfare. Many infections and disorders will look very similar on the surface and may require advanced diagnostics to kind of tease them out. But it is, I think, good to note that we have pretty significant training and tools to help us root out the problem and determine the best course of treatment. And as always, we're happy to help.